Hello, welcome to Healthcare Chats with Diana. Hello, today we'll be talking about healthcare access for low-income immigrant communities. We will focus on affordable, accessible, quality healthcare as the main goal and talk about not only the harms, the institutions and social aspects that play a role in them, and potential solutions, and our ethical responsibility to help address and achieve affordable, accessible, quality healthcare. Now let's talk about who is impacted by this lack of affordable, quality healthcare. A UC Berkeley analysis of the healthcare legislation that doesn't cover undocumented immigrants in California said that about 3.2 million undocumented immigrants under the California legislation that includes Health for All, Care for All reform, and the Affordable Care Act, along with Medi-Cal, is 3.2 million. We'll get into the nitty-gritty details about this policy, but that's just a gauge of just California. Now, looking at it nationwide, the U.S. National Health Organization, the NIH, released that about 33% of uninsured or unaccess to healthcare is actually the immigrant community, while U.S. citizens only account for 12% of the uninsured or non-access to healthcare. Looking at the extent of the lack of affordable, accessible, quality healthcare, we can talk about central capabilities as just a first response. Now, how are we going to define central capabilities for our conversation? For our conversation, central capabilities are the ones described by Nussbaum, but we're going to condense it down to only the top 5, just for simplicity. First, just life, having the ability to exercise your power of quality of life. The bodily harms, being able to address potentially bodily harms, which here may be chronic illnesses or being unable to attend an immediate emergency where you hit yourself with a hammer or anything of the sort. Another situation could be control over the environment. The immigrant population already has a limited amount of control over their environment due to one, fear of deportation, 2, language barriers or other barriers such as cultural shocks, cultural differences. 3rd, just managing the differences in having to move across a country. Or even the ones that sometimes are overlooked but are essential to having a good quality of life, such as play or imagination. Traditions, cultures all carry different ways of expressing play and imagination, so these are just a couple of the essential capabilities that not having adequate health care to address your health actually doesn't allow you to enable them, but actually stops you from being able to exercise your essential capabilities. Another aspect that sometimes is very much overlooked and just right there is the ability to afford healthcare. If healthcare is so expensive and insurance is kind of required to be able to even go, if you can get past the language barrier, the applications, the time management, and all these other social determinants of health that get in the way of just being able to go, looking at how expensive it can be, taking time off work, looking for a babysitter, looking for any of that sort is greatly impacted. Now, what about the fear? I talked about very briefly a few seconds ago, the fear of deportation is something that is prevalent in many of these communities, especially if they don't have the language capacity or knowledge to be able, or fluency, to be able to take an exam for an actual identification if they are not here on a type of visa or refugee asylum status. And in a weird way, it's almost as if healthcare has turned from a necessity into a privilege, because it's not only very hard to achieve, but very hard to even maintain. Now, looking at not only the ability to exercise central capabilities, affordability, fear, healthcare privileges, quality of life, or not even looking at potential medications addressing chronic illnesses, precursors, and comorbidities that are associated with not having healthcare. Before moving into bigger groups and institutions that may contribute to this inaccessibility to quality, affordable healthcare, let's take a step back and look at not only the types of groups and maybe how different institutions and social groups actually contribute to this advantage and disadvantage of healthcare. First, let's talk about single-family status. Single-family status, according to the U.S. Census Bureau and the NIH, when looking at the statistical information, is a family that has all members of the household share a status, either undocumented or legal citizenship, residency, or some form of permanence. While mixed family status is when there is more than one type of family member in terms of documentation in the United States. Now let's jump into major institutions and practices that contribute to advantages and disadvantages of having healthcare. Like mentioned before, healthcare impacts all these other social determinants of health and exercises of central capabilities, but we also have to consider that beyond these major institutions, like these disadvantages also inhibit from potential things you want to do, and also remove certain advantages that having good health give. Often overlooked are media representations, language and political rhetoric that surrounds not only immigration but healthcare. For example, if we jump into how that applies into private healthcare insurance, the cost of private healthcare insurance is often, according to the National Conference of State Legislation, Health Insurance's premiums and increases. In 2018, the annual average premium for employer-based family coverage rose 5% to $19,616 for single coverage. Premium rose 3% to $6,896, which equates to about 18% of a worker's contribution or salary. In 2017, it was about 18,000, and those who are fully covered, it's a lot of pocketbook impact on ordinary families, because with subsidies it was an average of $201. So anything that your insurance didn't necessarily cover for privatized insurance. As you can see, not only is it costly, but there's also eligibility criterion and applications and backgrounds to be met. And for the immigrant community, some specific barriers or practices that contribute to the advantages and disadvantages of this healthcare is not only the representation in physicians and the ability of the physician to communicate or to understand the symptoms and other needs of the patient, or the patient's ability to ask questions. The eligibility of some of these private health insurance requires Social Security number, which undocumented individuals would not have. And this demographic shift across the United States, not only of immigrants, but of ethnic and racial minorities, is not represented in the healthcare system. So even there is a discrepancy in terms of seeing someone who looks like you and understands you. Moving over to Big Pharma. So medication costs are still on the rise, and thanks to programs such as GoodRx, you can get discounts, but sometimes medications can still be a great burden on families. 3, healthcare legislation. Sometimes they are not inclusive in terms of immigration status, or even in what defining poverty, the poverty line or eligibility is. So if we were to look at the statistics for California, which is going to be our center focus for the solutions, to be able to qualify for Medi-Cal, a single individual should not earn more than $17,609. For a family of 2, $23,792, and for a family of 4, $36,156. So this is California's Medi-Cal eligibility criterion. So looking at that healthcare legislation there, that eliminates a lot of individuals who may just be right above the medical eligibility. Now, looking at health and hospital costs, again, it comes down to the costs. The way hospitals are organized, a lot of patients don't even know that hospitals are a safe bet because there's still the fear of debt and the fear of deportation as an unsafe area, since they're not sure of how things are going on. There's also this kind of doctor-patient kind of hierarchy where the doctor's kind of the dominant in the conversation, especially if there's a language barrier, and the patient is supposed to be the subordinate, along with stereotypes of ignorance and inability to express what is needed. Now that we've talked about the institutions and social groups, at least at a level of looking at not only how they pose a challenge to getting healthcare, and now that we know the healthcare issues and how healthcare is important, but we also talked about greater impacts that they may have in terms of not only private health insurance being an issue, big pharma, healthcare legislation, all of these combined issues or obstacles actually pose a disadvantage for these individuals, not only ability to move forward, but their ability to contribute even more fully to themselves and their loved ones, or even to their communities. Stepping away how these could be advantages and disadvantages to the immigrant community, let's talk about like if someone who is there to compete only for a job or is trying to do anything that may have another person at play, you can see how this person who is disadvantaged in a way gives an advantage over to someone, almost like a two swords type of situation. Or how does this advantage communities who aren't identifying? Is this allowing them for more resources? How does this come into play? Well, as we talk about like maybe why people should be opposed that we extend my proposition over to healthcare access, our current healthcare access in California through Covered California to everyone regardless of immigration status, beyond the 5 points that are listed on the website. On episode 2, that you will also find on my link below, you will be able to actually see how and what are the eligibility criterion to be able to apply for Covered California. But moving away from that specific episode, I want to come back and talk about like what could these potential solutions to address these structural injustices or these harms be. Well, let's look at something first. Should anything be done? Well, if we look at all these advantages and kind of positions of inhibiting somebody's ability to have the best quality of life, we are creating a difference in the playing field. Let's look at this in a different way. For example, is this unjust, not offering healthcare to these individuals who are in the country, who may be in the country illegally? Well, they are community members, and they contribute to our society beyond just the monetary contributions. So let's take a step back into my recommendations, and we can cover some potential oppositions and potential answers if there's any to these oppositions, and also touch upon like some ethics behind this and why it's actually our moral responsibility to help our neighbors and our community members have healthcare access, and how it would be unjust to not contribute or work towards giving healthcare that is affordable, accessible, and quality to these communities. Expanding upon the current Covered California legislation. But before we jump into that, let's look at the history. So, the Affordable Care Act was passed in 2010 by the Obama administration. And the current California healthcare system and the Affordable Care Act kind of mushed together to expand on Covered California, which is kind of like, you can think about it as the headquarters of healthcare for California natives and individuals who reside there. So it was expanded to include anyone under the age of 21 in the last 10 years, and then expanded again to include everyone over the age of 65. And again, this last year to include individuals 26 and under. So on the 26th birthday, that'd be the cutoff date, and 55 and under. So that's leaving a gap of 26 to 54 years old who are not covered under Covered California or would be ineligible. We talked about medical eligibility, and then we talked about like very briefly the immigration statuses that you must have. So this has to be like a work permit or like maybe a U visa, like that's holding pending status. We can talk about like the different visa types in a different episode. And then third, we can also talk about how being DACA, refugee, or asylum status, or having some permanency via a visa is also an eligibility requirement. So that would mean that the 3.2 million individuals that UCLA and UC Berkeley condensed legislation for us early on. I will also have like a link and a bibliography attached to this podcast so you guys can get additional information throughout it. But the transcript of this podcast will also have everything cited for everyone if you're interested in looking at it further. But going back to Covered California, it's this website that I will explain in a different podcast, like how it works, but it allows you to match the best, most economically best solution of healthcare for yourself and your family. Now, if we go back over to my solution, I would like to talk about how Covered California could actually expand on the health for all and care for all associations and coalitions to not only edit its requirements on documentation statuses needed and documentations that you need to provide for, but also talk about like how Covered California is not only funded federally but statewide through taxes and allocation of funds. So Governor Newsom actually suggested this change in ratification, and it's expected to include the 26 to 54 age group, but again, it still poses a challenge to over 3.2 million individuals as of now, plus more, who are not accounted for in terms of their ineligibility due to documentation status. So let's talk about like how feasible this is. So a couple of people actually talked to me and were like, hey, Diana, how are we going to fund this? And my answer to them was like, it is not only federally funded, but it's state funded and our taxes contribute to it. There's not going to be an increase of taxes or anything of the sort. And so they asked me like, hey, how is giving our federal taxes individuals who have chosen to come into the country and not receive these benefits, like knowingly knowing this, why should we allocate those federal taxes there when we can allocate them to improve a different issue? Or what about the doctor shortage? Wouldn't that increase wait times? Or like, what about our taxes that we pay ourselves? Well, to answer some of those, not rebuttals, but like just questions of, I do this part for my country, why am I contributing to this? Well, I'm talking about like federal budgetary. Yes, this is like a federal budget, but like federal taxes are also collected. So these individuals are not only your community members, but may have kids with like mixed family statuses who actually are U.S. citizens, and their like parents are also part of their community and like family, and also need this support to be able to provide them with a great life. Not even looking into the developmental psychology behind it and like quality of life at home, but looking into just like taxes in themselves. Like there's taxes collected at the grocery store and rent and property ownership. A lot of people don't know this, but in the state of California, a social security number is not a requirement to be able to purchase a house, but like ITN numbers is another way that individuals can pay taxes and contribute to their country, or to the country that they reside in. Even looking at like the doctor shortage, like wouldn't it make sense that like in allowing that these individuals have optimal health care and are able to exercise their capabilities, they would potentially even be able to go back to school, or encourage their children to have a positive affect and correlation with doctors, and maybe even send them over to better STEM programs, or send them over to like encourage them to become doctors. So these are just like a couple of answers to maybe why it's not my problem, or why them, or why shouldn't these resources go to me directly, can be answered. But looking at it like ethically as our responsibility. If we look at a utilitarian approach, for example, wouldn't it make sense to maximize the healthcare of everyone, to reduce costs in big pharma, or reduce costs in like people being unable to do their jobs and relying on different forms of aid, reducing just those types of costs, but also just maximizing their experience. Like these people are our neighbors, are not just like an untangible force or an other. They're actually part of our community members. Or even if we look at like a contractualist approach, if somebody literally came knocking at our door, like knock knock, could you justify not giving them the healthcare access that they need because of a different thing that wouldn't really offset or improve your likelihood or life, or maybe just increase wait times? Is that really justifiable to say, oh, we can't expand over because of increased wait times, when in reality this chronic illness or this fatal illness that could be stopped is not being treated? If we look at like the contractualist approach even and utilitarian approach combined socially, like in the community, like these people do contribute to the economy, socially, like with their kids, culturally, they're able to even donate blood on their driver's license, donate organs. They are a big part of the workforce, and sometimes the workforce that a lot of individuals don't want to be a part of, such as field work. Now, like, if we were to remove all that aside and you're like, but why me? We can look at the veil of ignorance that Rawls looks at it. If you were not to know like what lottery of birth you were going to be handed, would you want this health care? Would you be able to deny yourself this health care? And going off of that argument that we all kind of, or everyone should want to optimize their healthcare, exercise essential capabilities, not live in fear, and have control of their quality of life, and potentially, reduce getting or dying of heart disease, cancer, or just accidental deaths that could be prevented, wouldn't we all say yes? So, looking just at these reasons, I suggest that we increase the Cover California over from the Health for All and Care for All coalitions to include anyone who is a resident and a community member, not for free, but even at a reasonable cost. I think that is a misinterpretation that is often construed into when I say affordable quality healthcare. I'm just talking about getting people healthcare when they need it and healthcare that they deserve, allowing people to ask for questions, not to have to sacrifice horrible wait times, flexibility in terms of schedule, just being able to remove one of the burdens and allowing individuals to receive healthcare at a cost that does not create a great burden on their family situation, and also allows them to ask questions, get all the resources they need, and prevent further damage, and just optimize their essential capabilities exercising. So with that, I leave y'all with this question, if you were actually under the veil of ignorance, would you want healthcare? You're an active member of the community. If we were just to remove that status, would you look at your neighbor and deny them healthcare? So with that, I urge everyone to call your senators and see how you can contribute to, making healthcare more accessible, quality, and affordable for everyone. Before I leave, I do want to say a transcription of this podcast will be posted not too long after today, and I will also include a how to get in touch with Covered California and talking to information of congressmen, your legislator, and just making sure people are involved. If y'all want a more structural breakdown of the numbers behind the taxes, doctor shortage, and Covered California timeline, that will also be included in a second podcast video. Please follow up, and also I'm happy to answer any questions. Send them down or comment below, and I'll be happy to help them. Thank you, and thank you for listening. Thank you for joining us for Healthcare Chats with Diana. For more information, please visit our YouTube page, Healthcare Chats for Diana. 2 additional podcasts will follow explaining how Covered California works and what health insurances you can be eligible for. An attached bibliography in the comments section or in the description of this podcast will be found as well. Hope to hear back from you guys soon on the comments, and thank you very much.